Good morning and welcome to Grand Rounds. I'm Patricia Burke, Department Head of Pediatrics and Child Health. I'd like to acknowledge that we live and work on the original lands of the Anishinaabe, Cree, Oji-Cree, Dakota, and Dene peoples, and the homeland of the Métis Nation, as well as the original lands of the Inuit. We respect the treaties made on these lands, and we acknowledge that our offices are located on Treaty 1 territory. We acknowledge the lasting impacts of colonialism and ongoing systemic racism on Indigenous communities. We recognize that we all have a responsibility to stand against ongoing injustices. We dedicate ourselves to work towards equity, justice, and reconciliation, guided by the wisdom of our Indigenous community members and colleagues. It's my pleasure today to introduce Dr. Lauren Kelly, who is a pharmacologist and as of September 1st, an assistant professor in the Department of Pharmacology and Therapeutics, after spending the last 4 years based with us in the Department of Pediatrics and Child Health. She is a certified clinical research professional, the clinical trials director for CRIM, and a clinical trialist at the George and Fay Yee Center for Healthcare Innovation, where she supports methods development for a wide variety of clinical trials in Manitoba. Many of you have also met her in this role. Dr. Kelly's research evaluates drug safety and effectiveness in children, and she has authored more than 50 publications in this field. Dr. Kelly holds funding from a variety of public agencies and serves as the scientific director of the Canadian Childhood Cannabinoid Clinical Trials C4T team since its inception in 2018. She's going to talk to us give us an update on cannabis used for therapeutic purposes in children. So I'll stop screen sharing, and it's now time for some coffee and cannabis. All yours. You're on mute, Lauren.
Of course I am. You know, it's only been 18 months. You think I would have figured that out by now. So you can see my full screen and you can hear me all right? Great. Well, thanks, Patricia, for the introduction today. Before we get started, so hopefully you have a cup of coffee in hand, I do have one quick poll question for Cheryl to launch. And the question is, has a patient or youth or parent or family member ever asked you about using cannabis for a health reason? We're going to leave this up here for like 30 seconds, and then we're going to dive in because I have lots and lots of updates. So 10 more seconds, get your last votes in. I don't see too many coming in, but I will share the poll, and you'll see that about 3/4 of you report that someone has asked you about using cannabis for a health purpose in a child. So the update we have today is going to be extensive. I have lots of information to share. And the first thing is my top wellness tip. So I was asked to share my top wellness tip for managing life during the pandemic. And really that has been to celebrate the small wins. You know, not all of our wins will make it onto the CV, and we should celebrate these anyway. So what that looks like for me and my family is celebrating the little things, getting outside, having some adventure days, and some very successful crafting projects. A few disclosures before I get started. So I am the scientific director for the Canadian Childhood Cannabinoid Clinical Trial Platform. I am also a scientific advisory board member for Health Canada at the Health Products Containing Cannabis Committee. I sit on the board of directors for the Canadian Consortium for the Investigation of Cannabinoids. I hold funding, as Patricia mentioned, from a variety of public agencies, and I have no financial conflicts of interest to declare. Now, a second disclaimer is that the focus of this talk is really on medicinal cannabis, which, when I say the word medicinal and medical cannabis use, encompasses any cannabis use for a therapeutic intention, whether this is authorized or not. I won't have time in this short 50 minutes to discuss recreational cannabis use or accidental exposures. I also won't have time to discuss the role of cannabinoids in opioid sparing. Please don't take anything that is said today as direct medical advice. If you have a patient patient that you would like some consultation on, we do have a network of pediatricians and subspecialists that are often able to provide a little bit of insight. So if you do have a particular question, please don't hesitate to reach out. I will be discussing off-label use of medications, which is probably not a surprise, given that there aren't any on-label medications for cannabis use. And some of you may remember me from my last grand rounds in 2018, where I spoke lots about trial design. And unfortunately, the trials lady doesn't have very many trials to discuss. So I'll talk a little bit about cannabis, how it works, a little bit about the plant. The focus today is really on safety and toxicity, as well as the current knowledge on indications. Again, given the time frame, I'm really just going to focus here on drug-resistant epilepsy, pain, cancer, and autism, and then a few things about how we're going to close this evidence gap. So cannabis is a plant that's been used for more than 5,000 years, and medical use was first documented in 400 AD. The cannabis was actually even on the pharmacopoeia in the US and in Canada for headache, and it was removed in 1942, a little bit earlier here in Canada. And when we think about cannabis and cannabis products, there's a really huge spectrum of what this could look like, what the quality of these products are, what the consistency is in the manufacturing. And these include pharmaceutical agents. So Epidiolex is probably the most well heard of lately, and this is a cannabidiol product. It is not approved in Canada. They have not sought marketing authorization at Health Canada. It is approved, however, in the US, all over Europe, the UK, and Australia. This is a 99% pure CBD. So it is mostly a cannabidiol product. Sativex is approved here in Canada for spasticity associated with multiple sclerosis. It has no pediatric indications, and it is what we call a balanced product, so an equal amount of THC and CBD, but it's quite high in THC. When we think about kind of medicinal cannabis or some of the medical products that families are accessing, these come in a wide variety of formulations. Primarily, we have heard the most commonly reported is a high CBD plant extract, so a 1 to 20. So every 1 part THC, it's 20 parts CBD. So most of these are high CBD products. But then, of course, we have the recreational market, which has even more variability in the amount of cannabinoids that are contained in some whole plants products. And generally, recreational use is high THC products for euphoric effects. And this is because cannabis is really a complex plant. It contains hundreds of different compounds, including at least 60 phytocannabinoids. And this includes our delta-9 tetrahydrocannabinoid, or THC, and cannabidiol, or CBD. And these products vary greatly in composition, and they work on our endocannabinoid system. So the endocannabinoid system is there before you are born. It plays an important role in brain development and synaptic transmission and pruning. So even those that have never had a cannabis exposure, so including the teeny tiny humans that you all take care of, will have a functioning endocannabinoid system. It's sort of the eat, sleep, relax, forget, protect response. And it plays a wide role in a variety of physiological processes, including appetite, mood, stress response, and neurotransmission. We do have 2 endogenous cannabinoids, anandamide and 2-arachidinoglycerol, or 2-AG. And this is a relatively novel discovery. So these endogenous cannabinoids were only discovered in the 1990s by Raphael Mechoulam. And so we really are still learning quite a bit about the role of the endocannabinoid system. It's a complex network of receptors and signaling molecules that promote homeostasis. So it can be triggered by things like exercise, stress. There is some diurnal variation, pain or hunger, and the response varies. So things like appetite regulation, pain relief, coping with stress and anxiety. And their actions are mediated through CB1 and CB2 receptors. These are G protein coupled receptors that are found, again, throughout the body. So the focus of today's talk is really going to be on sort of the more well-known cannabinoids, THC and CBD, but there are other minor cannabinoids that I think we'll start hearing a lot more about in terms of their therapeutic potential, including cannabichromene, cannabigerol, cannabivarin, and tetrahydrocannabivarin. But again, this is sort of outside of the scope of today's update. So how does THC work? THC is a high affinity partial agonist for the cannabinoid receptors, preferentially for CB1. And it also acts on what are called the transient receptor potential of venaloid type 1 channels. And these respond to noxious stimuli. So they respond to things like temperature, chemicals, and hormone. And when we look at CBD, it's actually we call it promiscuous or a multi-target drug. It has lots of different effects. So anticonvulsant effects, anxiolytic effects, anti-inflammatory effects. And this is mediated through non-competitive negative allosteric modulation of the CB1 receptor. And that's a fancy word that really just means it binds to a different spot than THC binds on the CB1 receptors. So it can modulate the response that happens when THC binds. So we often hear of sort of a entourage effect, or that CBD can actually help make THC have a wider therapeutic window because it can modify some of the effects. There's lots of different ways that cannabis products are administered, and this won't be a surprise to any of you, but there are some challenges associated with each different route. So when we think about inhalation, that certainly has a rapid onset of action, and this is the primary route for medical cannabis use in adults. So if you ask, the majority of medical cannabis patients that are adults, they will say they prefer to smoke dried herb. Obviously, this is not something we'd like to see in pediatrics. But the ingested routes do have a low oral bioavailability, and there are certainly some challenges with taste and volume for some of the oil products. Cannabinoids are highly lipophilic, and so because of the pharmacokinetic characteristics of cannabinoids, both that they sequester in fat and that they have active metabolites, there's actually not a great correlation between what we measure in terms of cannabinoid concentrations in blood and urine and the degree of intoxication. The half-life of THC is about 7 days, but it can still be detected up to about 30 days. And this is really due to that sequestration in fat. It's cleared through our liver in the cytochrome P450 enzymes, CYP3A4, 2C19, and 2C9. And the maximum concentration is usually about 1 to 2 hours. However, this depends on how the cannabis was consumed, and it varies. So this has been reported up to 4 to 6 hours. Cannabis products, again, cannabis and cannabinoids affect almost every body system, and tolerance can develop, and withdrawal symptoms have been reported. And withdrawal has been reported even after short, or I think it's about 11-day exposures. And this is due to sort of the desensitization or the sensitization of the cannabinoid receptors. The acute toxicity is quite low. So, in general, there are no deaths directly caused by cannabinoid overdose. It's not like opioids where there's no cannabinoid receptors in the brainstem or the areas responsible for respiration. So they have, there are though deaths related to cannabis used with other compounds or traffic accidents, risky behaviors, those types of things. And there are possible long-term cognitive impairments and long-term respiratory, cardiovascular, and other health risks. Cannabinoids do cross the placenta and concentrate in breast milk, but they are not an identified teratogen. There are potential for long-term negative neurodevelopmental consequences following prenatal cannabis exposure. And the evidence is still a little bit unclear on this, on what the actual effects might be and what the risks are, simply because a lot of the literature is focused on high THC recreational cannabis use. And that comes with a lot of confounding variables and doesn't necessarily consider the sustained exposure of a medical patient. One big take home from today is that if your patients are using cannabis, you should talk to them and consider what other medications they might be taking. There are potential for drug-drug interactions. So CBD is a potent inhibitor of CYP2C and 3A. And repeated exposure can actually induce CYP2B1 and 2B6. And this has some implications for some of the anti-epileptic medications. So in some, epilepsies where we certainly have the most evidence for cannabinoids, and some interactions with clobazam and valproate. And anything that affects CYP3A4 is going to affect the concentrations of CBD and THC. Mild adverse events are quite common, but there are very few serious adverse events that are reported in the literature to medicinal exposures. Accidental exposures, though, have resulted in hospitalization. So we have partnered with the Canadian Pediatric Surveillance Program to launch a CPSP study looking at severe adverse events. So, reminder to anyone out there, this study we have been recruiting since 2019 in December. We have 5 cases that have been reported so far. Well, 5 cases that have met inclusion have been reported so far. A few more than that didn't meet our criteria. But please do review this. And if you have any questions, feel free to reach out to myself or to contact CPSP directly. So I say adverse events are common. This is a scoping review that is looking at literature up to September 2018. So, it's crazy to say, but it's almost even a little bit outdated when we think about the cannabis literature and how fast things are moving. But you can see here in a pooled analysis of studies that had more than 50% children between 0 to 18 years and excluded single case reports for any condition. Most of these were epilepsy studies. About 20% report somnolence, about 10 to 15% reporting diarrhea, decreased appetite, and some new onset seizures. Now, when I first agreed to give this talk, I was going to have very little to say about long-term safety. But luckily for me, this popped into my peripheral vision a few weeks ago when it was released. This is the long-term safety and efficacy data from the Epidiolex cannabidiol trials. So this is an expanded access program. So for those who finished the clinical trials, they stayed in the program to look for long-term safety. So this is a 2-year follow-up now, and this is the most data that we have on the long-term effects of cannabidiol. You can see here, this is sort of the adverse event profile scores. You can see they change over time. They do decrease a little bit. It's not significant, but it's important to note that they're not increasing. So they're not getting worse the more these products are being used. And there were 11 participants at 2 years that had elevated liver function tests. I think more than half of these were also using valproate. There were 27 serious adverse events reported over the 2 years. This included 13 hospitalizations and 13 rashes that are not defined at all. It just, they were classified as SAEs, unclear as to what those were. But overall, it is reported that cannabidiol was well tolerated. So that's a little bit about safety. Now the ever-burning question of does it work? And the answer really is, well, depends on who you ask. If you ask parents and families and the media, they will tell you that, cannabis products cure everything, and they are absolutely the answer to any child who has a complex condition. And, we know that that is not supported by current evidence. But these articles, they all have a common thread. And the thread is, this works for me and my family, but we are really missing the randomized clinical trials that are needed to change practice in this space. So what do we know? We know that cannabinoids, particularly CBD isolates and some high CBD whole plant extracts, have been used safely in children with epilepsy and have shown benefit. Nabilone has been shown. So nabilone is a synthetic THC. I'm not going to talk too much about it today. It does have a drug identification number, and it is used for cancer-induced nausea and vomiting. Some sites use it third line, and it has been shown to be safe and effective in children compared to chlorperazine. Purified CBD, again, well tolerated until 2 years. What do we know about withdrawal? What do we know about the risk of dependence in pediatric patients? Pretty much nothing. What do we know? We know parents are using cannabis products, though. So, 75% of this audience reported that they have had discussions with either patients or families about using cannabis products for therapeutic reasons. And in 2017, so pre-legalization, 50% of pediatricians surveyed by CPSP reported managing at least 1 child using medical cannabis, and 22% were managing 5 patients or more. So this is not an insignificant number, considering how little evidence is actually out there to guide, supporting those families. Only 46% of pediatricians and subspecialists, though, believed that there was an appropriate indication for cannabis use in children. And so of those 46 pediatricians, so of those people who believed that there are appropriate indications to support authorizing medical cannabis, primarily physicians were comfortable authorizing cannabis in palliative care, in epilepsy, chronic pain, and spasticity, and less so for acute pain, anxiety, or ADHD. My team is working on a living systematic review that will feed into an evidence portal we're creating online. So this is up to March of 2021. We have included now, you'll see here, 550 studies. Our inclusion criteria is a bit different than the scoping review from 2018, but there are 118 interventional studies and 142 observational studies. And this includes over 1,000 patients that have received intervention. Almost all of these are in epilepsy. And observational studies, we're talking more than 25,000 children. Evidence. So what do we know? So I'm going to start with epilepsy. Again, Epidiolex, where we have the best data and best randomized controlled trials on cannabidiol. It has been approved, as I mentioned, in other jurisdictions for treating seizures in Lennox-Gastaut syndrome and Dravet, and seizures associated with TSC in patients more than 1 year of age. I have the dose information on here. I won't read through it, but it's on here for your reference in terms of what's been approved. And there are some warnings on the label, which include liver injury, elevated liver enzymes, and an increase in clobazam concentrations due to some drug-drug interactions. So the doses, just to compare, so the doses used in the Epidiolex studies are a little bit different than some of the dosing that's used in some of the other epilepsy studies looking at whole plant extracts. So in terms of some of the whole plant extracts that include small amounts of THC, these are some of the dose ranges that have been reported in the literature. And in terms of some of the whole extracts, this is early or preliminary data from a study done here in Canada, of which we recruited a few patients here in Winnipeg, looking at a 1 in 20 product. So again, a high CBD product, the number of seizures per day. So you can see overall, there was an increase, there was a reduction in seizures from baseline for pretty much every participant. And some participants even had 100% reduction in seizures. So this is again from the Epidiolex research run by Oren Davinsky, looking at patients with LGS. Again, I think the studies are about a half split with the adult and pediatric age group. And you can see that with the 20 milligrams of cannabidiol, they actually showed more patients were able to get to that 75% reduction. And this is after 14 weeks of treatment. And a quick summary of some of the Epidiolex literature. So what you can see here is the seizure reduction with CBD really ranges overall around to 30 to 40% reduction in seizures compared to placebo, which not all of them are placebo controlled. But you can see that there are some important considerations around the placebo response, because of course these are parent reported seizure frequency and intensity. In terms of long-term efficacy, you can see, again, this is from that most recent paper, that after 2 years, the pediatric is the solid gray line, adult populations are the dotted gray line. You can see that over time, seizures, there was still a change in seizure frequency, and this is a change in seizure severity. So you can see something is happening where maybe it's not working as well. And this is really mirrored by what we saw in reported dosing. So you can see that parents and families were kind of hitting maybe a roadblock where they weren't seeing as much improvement in severity. So they're actually increasing their doses. So again, they started at a 5 milligram per kilo dose, and you can see that over the time frame, they're actually increasing. So by 24 months, the average dose used was 24 milligrams per kilo of CBD, plus or minus 11. So the mechanism, can cannabis and cannabinoids, particularly cannabidiol, help with epilepsy and reducing seizures? This is still unclear. So the proposed targets are again through the TRPV1 channel and GRP55. and suppression of voltage-gated channels that may play a role in decreasing the release of glutamate during seizures and preventing further neuronal hyperexcitability, which may help in terminating seizures. So what about pain? Pain is one of the most commonly reported reasons why people are using medical cannabis. Could cannabinoids work in pain? Preclinical data does support this. So preclinical models, tail flick studies in rats and some other animals have supported that cannabinoids can influence nociception, and they reduce alterations in cognitive and autonomic processing in pain states. And the distribution of the cannabinoid receptors, primarily in the frontal limbic brain, suggests that it may actually target the effective qualities of pain as well. And it may attenuate low-grade inflammation, contributing to an overall reduction in pain. So in adults, cannabis consumers, pain is by far and away the top reason why people are looking to use cannabis products. So what do we know? Again, what we know mostly comes from the adult literature here. So there have been 36 placebo-controlled trials for cancer use or cannabis use in chronic non-cancer pain. Compared with placebo, cannabinoids have shown a significant reduction in pain. Serious side effects were rare and similar across groups, but there was an increased risk of non-serious side effects. So there was more side effects with cannabinoids compared to placebo. But you'll see here, so this is just an evidence summary looking at pain measured by a visual analog scale. And again, these studies are all in adults, and some of them are looking at different products. So you'll see a few studies listed more than once, and that's looking at different product types. But you can see overall here at the bottom, the synthesis of these studies do support that cannabis may play a role in non-cancer pain. And I thought this was a really interesting study that was done looking at placebo compared to a high CBD product in green, a balanced product in red, and a high THC product in blue. So if you look at pain scores, you can see that the greatest reduction and change in NRS happened with both the balanced product and the high THC product, but these seem to equal out, 180 minutes after exposure. Pain pressure thresholds was also highest with the balanced product, but so was the drug high. And this is probably not surprising because, these products contained more THC. But what's interesting when we think about the pediatric context is how we characterize highness or intoxication related to THC. So there's not necessarily really well validated measures for us to assess intoxication related to THC in children. With adults, you can ask them if they feel high or if they're feeling different, but some of the pediatric patients are, of course, nonverbal, and it might be a little bit more difficult to communicate that. So recommendations from the European Pain Federation are, again, that cannabis be used only by experienced teams and as an adjunct medication, and it could be reasonably used as a third-line therapy for neuropathic pain. And children and adolescents are absolute contraindications apart from exceptional circumstances. So we'll leave that open to your own interpretation. Unfortunately, I have very little to say about pain studies in children because there are no RCTs of cannabinoids for chronic non-cancer pain in children. So stay tuned for the next update. Hopefully I'll have more to say on that. In terms of cancer, adult studies have shown a role for THC and CBD combinations to manage cancer pain. Nabilone, again, is used. Nabilone is a synthetic cannabinoid that's used third line for chemotherapy-induced nausea and vomiting in children. And patients, a lot of patients, up to 95% of patients who have brain tumors are trying to access THC products. There's a big push in parent communities, given some of the studies that are happening in the US around glioblastoma, that that there is some potential for cancer cure as opposed to just symptom management. 92% of Canadian pediatric oncologists care for at least one child using cannabis. So some of the data I'm going to share next has been put together by some of your fellow pediatricians here at the University of Manitoba. So we received a team grant in 2020 to study cannabis use in children. And this funds C4T, and our demonstration product is in pediatric oncology. We've partnered with a group in Australia. We were actually funded independently, designed our trials independently, and designed almost identical trials, which was very fascinating. And we're thrilled to work with our colleagues in Australia who have just gotten their ethics approval, so they will start recruitment this month. Our trial is still in the regulatory space, so we are hoping to start our recruitment early 2020. And this is a study looking at symptom management, is not looking at cannabis cure. Why focus on symptom management? Well, we asked, so Dr. Sapna Oberoi led a survey with pediatric oncologists and palliative care providers in Canada. And you can see that overwhelmingly, the response was that these studies are important and that they would like to enroll or would discuss enrolling their patients in these trials. So this is some work that was led by Dr. Stacey Chapman at Cancer Care around the patient and family experience. So patients and caregivers were provided the opportunity to complete a survey about using cannabis. And 25% of the respondents at Cancer Care reported using cannabis products in pediatric oncology patients. 100% of them reported improvement in their symptoms. Obviously, this is something to be taken with the caveat that this is survey data and is, of course, subject to response bias. You know, if you didn't want to participate, this was a completely optional survey. So perhaps those who had good experiences were more likely to want to share them. There were most improvements were in pain and nausea and vomiting and appetite. There were 2 patients who reported worsening symptoms, including sleepiness, diarrhea, and red eyes. So in terms of who reported cannabis use versus who didn't report cannabis use, there wasn't really a difference in terms of cancer type or time since diagnosis, but they were more likely to be in active treatment. So I think about 64% of those using cannabis products were in active treatment, compared to maybe only 30% of those who weren't using cannabis. In terms of what kind of cannabis products were reported, so about 86% were using an oil formulation, 50% reported using inhaled cannabis. And this, I think, came as a surprise to all of us on the study team, and perhaps sparked an interest in maybe doing a little bit of education with families around some of the risks of inhaled smoke or vapor. The top way that cannabis was obtained was through a friend. So 36% were getting through friends, and 29% were getting either like from a prescription, had an authorization. They call it a prescription, but we know that it's an authorization because it doesn't have a DIN, and we're obtaining them from a dispensary. In terms of spending, about 50% were spending between $50 to $500 a month, and 21% are spending more than $500 a month on cannabis products. So this is not insignificant. We asked some perspectives about cannabis use in terms of cannabis causing harm and cannabis, treating symptoms. You can see here that most people actually disagreed that regular use of cannabis, and this is all participants, so this is not just those who are using cannabis products. You could see that they felt that cannabis, most people weren't agreed that cannabis helps treat symptoms, can help cure cancer, interferes with other medications. People were really less sure about this one, and cannabis use should be under the guidance of a doctor. Pretty much an even split over who said that they agreed or disagreed with that statement. So in the work that Sapna and colleagues did looking at physicians and palliative care doctors across Canada, so they enrolled 119 individuals into a survey. And you can see here that physicians felt that there was a role for cannabis products, primarily around nausea and vomiting, chronic pain, around cachexia and poor appetite, and some mood as well. Much less support for the role of cannabis as an anti-cancer agent. Physician concerns. So, the most common concerns reported by physicians were that they are uncertain of the benefits. Again, probably not that surprising given how little literature is out there. Missing dosing and safety data, uncertain product quality, uncertain side effects, and the potential for cannabis misuse. So moving on to autism spectrum disorder. So as we know, ASD is a pervasive developmental disorder characterized by deficits in communication and in social interaction and in restricted and repetitive sort of movements or behaviors and interests. And there's a large difference in the severity of ASD in terms of both linguistic, cognitive, and behavioral abilities. And so a lot of this work has been pioneered out of Israel. There's a group in Israel that started this work a few years ago with an observational study looking at 53 children or youth, so up to the ages 4 to 22 years that were starting cannabidiol. And they basically reported that there was some somnolence and some change in appetite, but these were generally considered mild. And mostly they saw improvements. They saw improvements in self-injury and rage attacks, improvements in hyperactivity, improvements in sleep problems, and improvements in anxiety as well. Interestingly, there's also some worsening that happened in anxiety. And this is mirrored in some of the adult literature as well, where the anxiolytic effects of cannabinoids can go either way. It can either be, there are people who report, anxiolytic effects and people that report increased anxiety as well. So this led the Israeli group to conduct a clinical trial, which the NCT number is here if you want to look up more information about the trial. This is a crossover study in 150 children with ASD that have moderate behavioral problems. So they also have to have that behavioral problem component. And these are children and youth from 5 to 21 years. And you can see here that so the percent of participants with a positive response, this is their behavioral problems were measured using a clinical global impression improvement scale. This, I think, is a 12-week treatment response. And this is the percent of participants that were either very much improved or much improved. So you can see with placebo, there's still some placebo effects happening. About 21% were feeling better. With the whole plant extract, though, this is up to 50%. And they did see a significant difference, but only when comparing the whole plant extract to placebo versus pure cannabinoids. So they actually worked with a licensed producer. So this was a industry supported, I should say, it wasn't solely funded by industry, study where they actually made a pure cannabinoid, a pure CBD, similar to sort of the Epidiolex product as well. And they did see also positive effects, but again, not as strong as with the whole plant extract. So, this is the little bit of evidence that I do have to share, but certainly I have a lot more questions than I have answers at this point. Things, about how do we know what products work and what combination. We've been doing a lot of work with youth, and some of the things they will tell you about what they know about cannabis products may surprise you. They may be using different products at different times of day. They may use one product during the school day and one product on a weekend. And what do youth know about cannabis products for medical purposes? And what are some of the policy implications about that? And really, we don't have any answers on that yet. So how are we going to move this field forward? So we really need to be treating cannabis used for a medical purpose like we would any other drug. We need to talk to patients and families about it. We need to recommend consistent products and high quality products. We need long-term safety studies. We need rigorous evidence to support families as well as healthcare providers, because it doesn't feel good when you don't have an answer to give a family, right? And so we need better ways to communicate the evidence that we do have, because certainly, this is not something where we can say, well, it's never been studied in children. It certainly has, just not necessarily in the types of study designs that we would consider for practice changing evidence. And cannabis is still illegal in many places. So this, globally creates some barriers for, large scale clinical trials. Regulatory pathways for drug development are really not clear for multi-jurisdictional research. So I will tell you that we are already working now with the licensed producer in Australia for our eventual phase 3 clinical trial after our pilot studies are done independently. Because there are lots of import regulations and manufacturing requirements that need to be met. Again, cannabis is a very complex plant, and we're starting to hear, I think, the first cannabivarin genetically modified variant, because these are minor cannabinoids. They're found in very, very small amounts, but there's starting to be plant modification to increase the yield of these minor cannabinoids. So there is going to be even more new cannabinoid products to talk about, in another year or two. There are various ways that cannabis is used, and really a lack of data on medical exposures. And why is it important that we talk about medical exposures? Well, recreational exposures, we have that ebb and flow. It might be, 2 joints on a weekend and then nothing throughout the week. It could be an acute exposure. This again could be chronic. These are mostly inhaled routes with the intention of, recreational benefit, usually high THC products. If you look in the literature, the description of the exposures is atrocious. So you'll get something like smoked 1 joint a week. I mean, that doesn't really tell me much about what's in that joint, how much smoke was inhaled, how was it shared, how much was inside of a joint. I mean, really, it's impossible to quantify that kind of exposure. And most of this is done in adults. There is, of course, some literature around unintentional exposures in children. Children find the gummies that look like fuzzy peaches or whatever, and can end up with some serious adverse events. And of course, with recreational exposure, there's unaccounted for shared risk factors. So people who use cannabis in adolescence are more likely to also be using products like alcohol and tobacco as well. And why is this different? Because in medical exposures, we're really talking about chronic conditions. We're talking about often many concomitant medications that need to be considered. Oftentimes, these are complex care kiddos. Their daily use, and it's controlled dosing. So generally, we know what are in the products, or we have a good idea of what's in the products. Oils, creams, sprays, capsules. There's lots of other routes that are not smoking that would be certainly preferable for children. These are generally high CBD products. And of course, as I cannot state enough, there's really limited studies here. So what do we think about when we're designing our research moving forward? Is that really unique populations create variability in perceived risks. And what do I mean by this is that using cannabis in a child who is palliative or has a DIPG diagnosis is going to look very different than using cannabis in an otherwise healthy adolescent who has sleep problems or who has claiming to have anxiety concerns that they're self-medicating with cannabis. These are very different risk profiles in terms of what the long-term safety might look like. There are placebo effects. Certainly, lots of people think cannabis is a magical cure-all, so we really need to advocate for placebo-controlled trials. Control group contamination becomes tough. And this is because, well, cannabis products are available. So outside of a trial, outside of clinical care, if a family feels that they want to use cannabis for their child, they will use cannabis for their child. And so that creates some challenges for both clinical care and for research, because it could potentially contaminate a control group. If they know that they're not getting cannabis products and they really want it, they could be using it outside of the context of a study. There's potential for cannabis withdrawal syndrome, although, again, this is not well described in children. There are access concerns, travel and driving considerations, as well as reproductive considerations and counseling for contraceptives. Measured of highness or degree of intoxication, again, not well validated, particularly in the nonverbal kiddos. And there are regulatory and manufacturing barriers. Could fill a whole hour harping on the regulatory barriers. I that, but certainly conducting research is not as supported as it could be here in Canada. And so all of this led to the Canadian Childhood Cannabinoid Clinical Trial Consortium. We started in 2018 through really a grassroots group of individuals convened through MyCern that were trying to answer questions about cannabis kind of ad hoc, and we received some questions from Health Canada, and we thought, you know, we don't really have a mechanism in place to study cannabis in Canada. Since 2018, I will tell you, we have more than 21 projects now ongoing. Some of them have been completed, as you heard from Sapna's study and Dr. Chapman's study as well. And this includes 2 clinical trials. So we have funding for 2 tolerability studies. These are interventional in nature, but are not controlled because the primary goal is safety. We are looking at adverse events and dosing. And these are called CanPonc, which is in pediatric oncology for symptom management, and CanCDH, which is for chronic daily headache and funded by the Sick Kids Foundation. Please visit our website and you can learn lots about all of the other projects we have going on. These range from ethics projects to school policy projects to a living systematic review. We have an observational real world evidence study launching soon, and these trials as well. So lots of different kinds of research, certainly all of which is not led by myself. We have established site leads. So one thing we heard quite loud and clear was that people had nowhere to go. You know, if a patient was in their office and asking about cannabis and looking for advice on products or dosing, is that pediatricians didn't know where to get information. And so what we have done now is through our membership, so we have more than 100 members, and what we've set up are site leads. So each hospital now, we're missing a few hospitals in Quebec and in the Maritimes, we're still working on that. Each hospital now has a point person, essentially a site lead that can connect whoever has a question to C4T, and we have a variety of experts that can help consult. So for example, I also get parents that come directly to me, and sort of what that would look like would really just be a discussion with them around sort of, you know, what their concerns are. And then we would connect them with a physician who has some expertise in the area. And the caveat is that their physician has to attend as well. So any of these site leads or experts will not provide any direct medical advice, but will help counsel the family and the treating physician as well. So it's been a really great experience of helping to connect some people, helping to make people a little bit more comfortable with having these discussions, and also helping families make sure that they have access to some expertise. So feel free to send an email either to myself or to our generic account if you have any questions, or if you know any of these site leads and prefer to reach out to them, that is a-okay as well. So what we found in our oncology study was that really people wanted education. 96% of oncologists and palliative care physicians wanted to enhance their cannabis knowledge. 60%, that was the most common report, want an online portal with scientific literature. And that is what we're working on. So we will have a resource portal coming. All of the trials that make it, all of the intervention and observational studies that make it into our living systematic review, so we're talking now almost 300 studies, are all getting evidence summaries. And this, we're working with a web developer over the next few months to launch something really great, searchable, and interactive. In terms of other educational opportunities that are available, we do have a webinar happening November 8th and 10th that is on today's questions and tomorrow's answers, a journey to understanding medical cannabis in children. And this is spread over 2 days. They're they're short presentations by some physicians, as well as some parents and youth and research facilitators on medical cannabis. You can hear, we're going to hear about current trends. We're going to talk about how cannabinoids work and pharmacokinetics in kids. And then every road is different experiences from parents' perspective, accessing medical cannabis for their children. The second day is really focused on moving forward. So looking at building trust with youth. We have 3 wonderful youth partners that continue to work with us on designing our chronic daily headache study. And so they will present around building trust in the evidence, because we want absolutely, youth to come to us as a trusted source for information. And we're talk about medical cannabis in schools and some of the complexities around research. So this is a free webinar. Feel free to come and go as you like. If you register, I think they will send you the YouTube link. It's hosted by the University of Manitoba through StreamYard, and it will be streamed on YouTube. So I think either way, I'm happy to share the link to those once they are available. We are also hosting the rounds the following week. November is a very busy month for cannabis and pediatrics. So Dr. Tim Oberlander, myself, and Dr. Evan Lewis are hosting cannabis use for pain. And essentially what we're going to be talking about through the rounds are, how common is this? Is there a mechanism that why cannabis products might work for pain? Where can I find information? Evan and Tim will present some clinical cases. So, what do I do if I have a patient and their family want to try using cannabis to manage pain? So where do I find information? What do I tell them? And where do I start? So we're really looking forward to that. And this is done in collaboration and in strong partnership with Solutions for Kids in Pain. And the last thing I wanted to highlight in terms of education is that the CCIC, so the Canadian Consortium for the Investigation of Cannabinoids, primarily includes adult investigators and clinicians. There is a growing pediatric interest now with myself on the board. I'm trying to work on perhaps encouraging some development of a pediatric specific module. So the Canadian cannabis syllabus is CME accredited. So they have worked really hard and lots of experts have contributed to developing this education program. So it is available online if you go to ccic.learncannabis.ca. Or the contact info is here and you can register online. As I mentioned, there is no pediatric specific module, but this will give you all the background on cannabinoids and their potential uses. So in terms of some key points before I open up to questions is that the cannabis plant is very complex and there are a lot of different compounds in there. Cannabinoids act via the endocannabinoid system and play a role in homeostasis and stress response. Cannabidiol has shown benefit in refractory epilepsy. Cannabinoid health products are approved. So these are the Sativex and the Nabalones are approved for use in spasticity, pain, and cancer-induced nausea and vomiting. There is some low quality and anecdotal evidence supporting the role of cannabinoids for children with pain and ASD and cancer. Literature on recreational cannabis does not directly transfer to cannabis used for medical purposes. Products are widely available though, and I would really encourage everyone to discuss cannabis use if that is something that you think might be happening. And the response is highly variable among individuals. So in conclusion, interest in cannabis products for medical purposes in children in Canada is increasing. This is a huge area of growth and uncertainty. We still have very little rigorous data to guide dosing and safety. And clinical trials are needed to move medical cannabis in children from an era of anecdote to evidence. And this is going to take us some time and some investment, but we'll hopefully get there. And maybe I'll have a lot more to share in the next few years for some rigorous trial results. If you want to learn more about cannabis, please reach out to us at any time. We do have the webinars and the rounds. We also have monthly meetings and a newsletter. There are a few pediatricians from here that participate in those groups. It is an open door. We do ask everyone to complete conflict of interest disclosures. Only those who do not profit from cannabis are allowed to participate in C4T. It is academic and independent. And you can learn more about us on the website or follow us online. So with that, I'd just like to acknowledge all of our amazing partner organizations and our funding agencies, and of course, our wonderful and ever-growing lab here at U of M. We are on our 4th pandemic baby now. And with that, I will open the floor to questions.
So thank you, Lauren. An outstanding review, and in particular, thank you for your leadership in this very important area that's emerging in pediatrics. And we appreciate your openness to consulting for us, because I think many of us who have complex patients now have questions about cannabis. Our parents are coming to us with questions. So we appreciate that opportunity. There is one question from the audience. Joanne St. Vincent has her hand up if you'd like to ask your question now. If you are available, you can unmute your mic. Okay.
That's an error.
All right, then I will, thanks. I will read questions in the chat. The first is there a link between cannabis and gastroschisis? And as you know, Manitoba has among the highest rates of gastroschisis in the country and worldwide, actually.
I didn't know that it was worldwide. And certainly we were leading the route for Canada there. So not that I'm aware of. I haven't seen any links between cannabis and gastroschisis, no.
Next question, are there any long-term outcome studies in the recreational cannabis use in and educational outcomes for children and adolescents?
So there's not in terms of prospective studies. There are, I believe, some retrospective cohorts that sort of look at like, was cannabis used in pregnancy? Yes, no kind of variables that look at educational outcomes in children that I don't think have shown very much as of yet. But in terms of sort of following forward recreational users and looking at scholarly performance, I'm not sure that I haven't seen anything out there, no.
Okay. Question from Dr. Greenberg. Do you have an update on the work you've done on the level of CBD in newborn blood spots to give us an idea about exposure?
Yes. So Cheryl, thank you, Cheryl, for pointing that out. I didn't bring it up because it's not, well, I guess it is about kids. It's always about kids when we're talking pregnancy as well. But we did a study with CADM. So we've actually collected dried blood spots here in Manitoba from pre-legalization and post-legalization in collaboration with a group in Saskatchewan. And they have run only the data so far, Cheryl, for Saskatchewan and only for pre-legalization. So I should have that answer for you in like 5 weeks. Because we are next on the docket to get those Manitoba samples processed. So perhaps send me an email and I'll remember to update you when I have those results. But what they did find so far is that they had a 6% positive test rate pre-legalization in just the Saskatchewan samples. And that kind of mirrors what we read about in the literature, about a 4% self-reported rate of cannabis exposures.
Okay. Next question from Dr. Lane, who's an adolescent medicine specialist. She's seeing a number of adolescents with chronic nausea, and the common denominator is heavy cannabis use. We've certainly seen that on the wards, adolescents being admitted for cannabis hyperemesis syndrome, and any comments on that?
Yeah, I mean, certainly that's something that we are aware of, and it's particularly with high THC products and some edible compounds. So I think what we have also been hearing a lot is sometimes parents are thinking that like edibles, or if they have like a lot of oil, in terms of medicinal exposures and high CBD products, I'm not really aware. I haven't heard too much about cannabis emesis syndrome. I think this is more related to the recreational products and those that are high THC, and some individuals will, of course, are going to be more sensitive to that than others. And this is one of the reasons why when we do our studies, we're not actually doing traditional dose finding where, 3 patients here and then 3 patients here and 3 patients here. We're actually starting everyone at an extremely low dose, a subtherapeutic dose, and titrating up, because that variability is just so great. So I don't have any particular comments about cannabis hyperemesis syndrome with some of the high CBD products, but definitely something we'll look out for in our studies for sure.
Yeah, I can tell you it's hard to manage when they come into hospital. It is very protracted, the vomiting, and kids we've had have come in for up to a week for it to resolve. Last question for myself. Any recommendations for the co-administration with other drugs, or how we alter our administration of some of the chronic drugs that we use with the oil?
Yes, so certainly that's going to depend on which drugs we're talking about. But in terms of, if you look at actually the Epidiolex product monograph has a whole list of drugs and dosing considerations. So if you're looking specifically in a patient with drug-resistant epilepsy, that monograph is actually quite useful because it has kind of percentages that you should decrease the starting doses by, and obviously doing some therapeutic drug monitoring for valproate levels and clobazam levels, because those are areas where we expect there to be some interaction. interaction, but really, you know, the potential for drug-drug interactions with CBD is not small. So really, you know, looking into how these drugs are metabolized, I think, you know, I wouldn't maybe necessarily recommend starting out by modifying your dosing, but certainly being aware of it. And if there are any adverse events, you know, monitoring liver enzymes and those things, then adjusting accordingly.
Okay. Well, thank you very much. Again, outstanding presentation. And again, we look forward to some of your ongoing research, including the birth spots, and look forward to that data as it emerges. And we will certainly invite you back as you have more clinical trial evidence-based information. All right, we will see you all again in a week. Thanks again for attending.
Great.
Bye.
Thanks, everyone.